Well, here we are back with the YouTubes. Personally, I like doing the YouTubes because it gives me a chance to do my lecture and then go into the classroom and do my lecture. So I wish I'd have known before now. I would have recorded it sooner. But I am more than happy to do the YouTube for you guys. I really love you guys. Think y'all are just the greatest things in the world. And I am happy to do the YouTubes because I really do prefer to do the YouTubes rather than do the lecture in the classroom with the Blackboard Collaborate. But it was part of technology that was bought that we have to figure out the best way to use it. And so with your input, we're figuring out a lot of stuff. So I'm going to open up the PowerPoint, close myself off, and I probably won't get all this recorded today, but I will finish it up tomorrow. And I hope that it is a lot better for you guys. So here we go. Well, this is a lot of information right here. Okay, I was just teasing. We're going to go ahead and start with reviewing the structure, the function, aging changes, and assessment of the skin. Now, chapter 24 is all about the assessment of the skin. And I have done you a PowerPoint that has questions on it that just is to see how much you remember about the structure and the function of the skin. So I'm not going to record that one for you guys. I will give you the answers to the questions, but I see no point in recording it. If you have any questions about it, I will be more than happy to answer them. Just send them to me via YouTube. Now, understand that y'all are kind of concerned about me saying that this test would be hard. I didn't mean that the test would be hard because I'm making it hard so you can't pass it. That certainly is not my intention. My intention is to let you know that the content of this chapter, or not basically this chapter, but the content of all the chapters in this are a little bit more complicated than they appear on the surface, especially the one on burns. Most of you this should just be a review for you guys with the skin problems, because basically you see a lot of these even as an LPN and in your clinic. So you should just be getting a review from this. So we're just going to kind of slide through here, and I'm going to stress things that I need you to know. And we will just try to cover all this material and cut it down. And that was one of the things I was working on over the weekend, is to make sure that I can condense this material for you guys so it's not going to cause you to have a tremendous amount of things to have to remember. So just go back, and I'm not going to go over chapter 24 and review it, because that basically is just your path when you did your physical assessment in the spring is when we went over the skin and skin structure, and you had it in A&P, you had it in microbiology. There's really no reason that we need to go over that unless you want me to, and you can send me an email asking me through Blackboard. First thing we're going to talk about is the lesions. They're primary or they're secondary. Lesions is when it's the first outbreak, and secondary is when you have a change in that first outbreak. That's all I need you to know about them. There's a page in your book on 423 that shows you all the different types of lesions. Don't spend any time trying to memorize those. I'm not going to ask any questions about the difference between a bulla and a pustule. I'm not going to do that. That's just redundant. So only thing I want you to know is primary versus secondary. I do want you to know about the ABCDE assessment of moles. This is very important. Most of you probably already know it. And if you remember A, B, C, D, E, you won't have any trouble remembering it. Asymmetry of shape. If it's not a nice shape, then it's, if it has a strange symmetry to it. If the border is irregular. If your brown or black mole has some color variation, such as red, white, and blue, or red, white, or blue, those are things we look for. Diameter being greater than 6. And then evolving or changing in any features. That means if something changed about the mole. Even itching is a change in the mole. So if a patient says their mole has recently been itching, then we need to investigate that. There's some reason why the mole just all of a sudden started to itch. Maybe it's growing. So those are that I need you to know. And if you want to look at the lesions, you're more than welcome to, but I'm not going to ask you questions on it. All right, let's have us a question here. Your patient is 33. He's in traction. He had a fractured femur. He has a lot of dandruff, and the RN asked the UAP to wash his hair along with his usual morning care. The UAP reports that the patient refuses the shampoo because he's afraid that washing his hair is going to make his scalp even drier and increase the dandruff. So what is the RN's best response to educate the patient? Now, what you need to know with this question, which is kind of wordy, but what you need to know, what is causing the dandruff? If you know what is causing the dandruff, you know what you need to educate the patient with. So, are we going to use a shampoo for dry hair and do not use the hair dryer to avoid making the problem worse? Is that what we're going to teach him? I will ask the healthcare provider to request a dermatologist be consulted. The patient has a right, but tell him his dandruff can be spread. Or D, even though the flakes make it look like dry skin, dandruff is a result of excessive oil production. And D is the correct answer. Remember, we even talked about this when we talked about babies having cradle cap. It's due to the sebaceous glands being over-excreting oil. And the best thing to do is to keep it clean and to wash it often to get rid of the flakes. So dandruff is not caused by dry skin. It's caused by overproduction of oil. So, and none of the other answers would fit that. Okay, now we're talking about skin dryness or skin problems. These are just in general skin problems. Dryness, pruritus, sunburn, urticaria. All these are just basically some of your normal skin problems that we see. Dryness is really bad, especially when we don't have good blood flow. And when you get older, your blood flow to your skin is not as good, and so we see a lot more dryness in the elderly. The pruritus, of course, is itching. It's the result of the histamine effect that affect your nerve fibers. So itch is like pain. It's very subjective. You should rate it on a scale of 1 to 10. Some of the things that we can do for plan of care for people who have dry skin is that use a fatted soap like Dove. If we're going to put lotion, we should moisten their skin first and put the lotion on after the skin is moist. It's best to do it after a shower or after you take a bath, because what we really want to do is hold in the water, the moistness that's on the skin, not so much the lotion as the water, because we want to hydrate the skin back up. Should rinse all the soap off. Make sure it's thoroughly rinse any soap that you use. Don't rub dry, but pat dry. And be sure that your patient's drinking about 3 liters of fluid a day, because that's the normal amount of fluid a patient needs to drink in order to stay hydrated. Some of the things that we can do for, of course, itching is that we want to make sure that, again, the proper bathing with rinsing the soap off, making sure there's nothing that's going to cause itching that's left on the skin. Be sure we're cutting those fingernails short. People scratch at night in their sleep and are unaware of it. Wear mittens at night. Cool, not a warm environment, even though the elderly like to be in a warm environment. A cool environment is a lot better for itching. Oatmeal baths are good, and of course antihistamines. And if you're going to apply an antihistamine topically to just a particular area on your skin, if you moisten the skin before you apply it, especially if you kind of do use a little bit of warm water to open up the capillaries, and you can put the antihistamine and rub it in, and it will actually absorb better. That's usually a good rule of thumb for just about anything that you put topically, as to that warm moisture will open up capillaries and will help with better absorption. Another thing that, even though sunburn is listed here, it's also going to be listed in your burns chapter, but it's something we deal with a lot. People get out in the sun, go to the lake, and they get sunburns. It's usually considered a first-degree burn, superficial burn. So basically, we all know it's overexposure. We know it's bad for us. We know we should be teaching people not to be out in the sun because it can cause skin cancers. We may see some blisters resulting from sunburn, and if we do get blisters, then it's going to result into a different type of burn. It'll go to a second-degree burn. The thing we need to do for sunburns when we first come in and we realize we're sunburned is to take a cool bath, cool cloth to the area that's burned. This is going to help stop the burning process, and that's one of the biggest things we need to do with any type of burn, is to stop the burning process. You know, you're frying a piece of meat, and the longer you leave the heat there, the more it's going to burn inside. So if you can get the heat cut back, then it's going to stop burning. So put the fire out, put a cool cloth on the area burned. Some soothing lotions or the sprays usually resolves in 2 to 3 days. Urticaria is usually the result of being around something that you're allergic to, so you want to just get away from whatever it is you're allergic to. Take antihistamines and avoid hot showers. And anytime you take antihistamine, which is a Benadryl, you want to be sure to tell your patients not to be drinking with it. Well, drinking alcohol. I guess they can drink water all they want to. So our diagnostic assessment, I did go back and pull this out of chapter 24 because I don't know why they didn't have it in this chapter. Be sure you always wear gloves, because any type of skin irritation is considered contagious, so you don't want to catch anything, of course. But I want you to know about doing cultures. A fungal infection, the culture, you use a tongue blade and scrape the scales into a clean container. Then you go look at it under the microscope and see what you see. Bacterial, you want to get this from an intact lesion if you possibly can. You can try to express the material from the lesion by squeezing it a little bit around it, and then collect the exudate with a cotton applicator and put it in a bacterial culture medium specified by the lab. Always whatever type of bacteria they're looking for. Sometimes you can't get the exudate to come out for either bacterial or viral, so you will need to use a sterile needle to lift the crust off. And then you want to swab the underlying exudate. So for the viral, be sure to use one of the sterile applicators. Obtain vesicle fluid from the lesions. You can raise the puncture it with a sterile needle to get the fluids to come out. And it has to be placed on ice and transported to the lab. So be sure you know the difference between the viral and the bacterial. You collect them the same, except for the viral has to be put on ice. There's different types of skin biopsy. I'm not going to ask you to specifically know about those. The punch is usually the most common one that we use. Sometimes they can shave all the way down to where the good skin is. We always know we got to prepare a patient for any type of procedure and what they should do for follow-up. Wood's light's an interesting thing because it's just a handheld ultraviolet light that when we use it during an exam, specific colors are produced to identify different types of infection. The endoscopy is just a painless technique to eliminate erythema so you can inspect the skin. So if the skin's really red and you want to inspect underneath it, you can press a glass slide down on the skin and find out, be able to assess what's underneath the red. Trauma. Trauma, of course, can be anything from a surgical incision to a grossly infected pressure ulcer, which we'll talk great depth about here soon. You should already have, in microbiology, you should have learned about the normal healing processes, how the 3 phases of the healing process, which is on page 433 in your book. Very good table to look at. The surgical incision without tissue loss are usually closed with staples and sutures, and healing occurs by first intention. Your secondary intention is when you have deep wounds that had some tissue loss and they require gradual filling in of the space, and that's your secondary. Your third intention is when you have like an open belly wound that may possibly been contaminated, be infectious. We don't want to suture those together. We want to leave them open so we can debride out the contaminants or the infection, whatever's in there, the dead tissue, and then let it eventually close. And then eventually we're going to close it. Once we get a good granulation in there and we see that it's healing, we're going to close it by first intention. So because we delay that primary closure, we know this as third intention. The scar of the third intention will be much like the first intention, whereas the secondary intention will have a greater scar, and of course any scar tissue is not as strong as the healthy tissue, skin tissue, and it's not strong, and it's always a point of weakness, possible possible development of pressure sores on a scar. So how's skin integrity restored? Through those 3 processes: reepithelialization, granulation, and wound contraction. Epithelial cells will cover the wound with cells. Granulation is what you're going to see at the bottom of the wound. It's going to be nice and pink and beef. It's going to start out as a nice pink color, and it's going to cross over. It builds itself little islands, and it gradually will start filling in the wound. And it might turn into a red color, but whatever it is, it's always growing, and it's moist, and it may be spongy feeling. If your granulation is not there, you do not have a good wound bed. You do not have good healing. And something you always want to look for is granulation to be there. Wound contraction is when the tissue on either side of the wound, if it has good enough elasticity, as the wound heals, it will pull itself together, and with the tissue surrounding it, as long as it's good and elastic, it will heal really well. If it's not, then we'll have some issues with that. And the depth of any injury and how much tissue damage is going to determine how long it's going to take to heal. So let's talk about some partial thickness, superficial. This involves the epidermis and the epidermal layers. Usually the partial thickness superficial will heal by production of new skin cells but undamaged epidermal cells. As long as we still have dermal layers that can produce epithelial cells, it can heal by just the re-epithelialization. It just regrows across the open area, resurfacing. It usually does 1 layer at a time, and then it'll thicken and start looking like normal skin. Usually takes about a week to do this. It will not grow if the wound is dry. It won't grow if there's eschar on the wound. So it has to be a good clean wound for this to happen. So what conditions can you think of that might impair healing? So some things that might impair healing: nutrition deficit, arterial deficits, dehydration, infection, comorbidities, certain medications like steroids, person being stressed, and smoking. Those are all things that will impair healing. Diabetics is one of your comorbidities. Sometimes, they lose feeling in their feet. They get the neuropathy. They don't even have pain. They just don't have any feeling at all. They can have an injury that can develop into a diabetic ulcer. They have a low blood supply there, and so their body is going to respond slower, and they're going to have a really hard time healing. Now, our full thickness pressure ulcers or wounds, the damage is going to extend into that dermis layer and into the subcutaneous tissue. That means that we're not going to be able to see epithelial cells producing new cells. So it's going to heal by granulation and contraction, and we already talked about granulation and contractions. So I'm not going to go over that again with you guys. So complete closure by contraction, again, depends on how elastic the skin is around it. So here's your question, a little review. You're assessing a patient's wound every day for signs of healing or infection. Which would be a positive sign of healing? Eschar starts to lift and separate, and beneath it's dry and pale. That doesn't sound very good, does it? How about the area appears pale pink, progressing to a spongy texture with a beefy red color? Okay, that's going to be granulation. It's going to start out pale pink, and it's going to start developing capillaries and actually be able to start having granulations. The granulation will eventually fill in the tissue or fill in the wound. So the answer to this, what are we going to do? We've talked about the physiological steps of the healing. So what order does it happen in? Well, first of all, the injury has to occur, right? So A is number one. Skin injury results in local inflammation and formation of a fibrin clot. Inflammation is your first response to a cut. Then number two is E. Growth factors stimulate epidermal cell division, and new cells move into the open spaces. Then fibrin clot acts as a frame to guide those new cells' movements across the wound. Then we have regrowth, which is only one cell layer thick, and then it gets more. And then finally, stratification, and keratin forms to resume normal skin. So the answer, 1, 5, 3, 4, 2. Now, am I going to ask this question on the test? It will not be to put them in order. You need to know though, about how wounds heal. We got to pressure ulcers today, so let's try to, we're going to get ahead of the traditional now. Pressure ulcers are, they're damage that's caused when skin and tissue are compressed, and they lose oxygenation to the tissue there, so the cells die, and that's basically what an ulcer is, and it can occur on any body site, and it's very difficult to heal. Our goal is to maintain or improve oxygen to the area that's being damaged. Positioning is critical to prevent pressure ulcers. You don't ever want to raise the head of their bed above 30 degrees, because if it's above 30 degrees, it causes them to slide, which causes them to have shearing. You want to manage moisture. You want to be sure that you keep your patient dry that's incontinent. You want to maximize their nutrition. Be sure they're getting high protein, high calorie diets to heal their wounds, and you want to minimize pressure that's existing that's causing us to have this problem. The RNs usually always do the RNs always do the assessments of the wounds because it is an RN scope. But LPNs can observe and document findings. In the nursing home, your LPN is going to be the one that's going to be observing and documenting the wound more so than the RN in the nursing home. And the LPN is perfectly capable of observing and documenting. And that's one of their jobs that's in their scope of practice. So keep that in mind. In our prevention, there's a big list on page 438 that gives a list of your best practices, and it's a really good thing to look at. Things that cause it, mechanical forces are going to be your pressure, your friction, your shear. The biggest thing we can do is to make sure that we identify all these high-risk patients. Once we identify those patients, we need to be real aggressive in what we do with them. Instead of just saying, oh, let's turn them every couple of hours, we need to be more involved than that. We need to be using pressure releasing, relieving tools, and whatever we need to do. So pressure is, of course, gravity. When you've got a bony prominence that's on a hard surface, so if you've got somebody lying on their hip all the time, they'll get a ulcer where their bone meets the hard surface. Same as with their sacral area. And it doesn't always have to be that way. Obese people can get pressure ulcers under their breast and under their belly folds from moisture and not being kept dry. But usually pressure has a lot to do with most of our pressure sores that we see. Friction is when we have surfaces that rub the skin. This is when you have a patient dragged or pulled up in the bed. And then shear is when the skin is stationary and the tissue below shifts. And usually you'll see this in patients who sit a lot in a wheelchair or in a semi-position in their bed. That's why we recommend 30 degrees and no higher with patients who are high risk for that. So we want to make sure that we're going to be aggressive in preventing pressure ulcers. We want to make sure that we do reposition them. In order to make sure that repositioning is done, we can post a turn schedule, should be posted at the head of the bed with what positions they were changed to, so we'll know what position to change them to next. And of course we want to keep those linens in the patients dry. Those are two of the biggest things we can do to prevent pressure ulcers. We have the Braden scale on 439 that is what most people's assessment tools in the facilities we go to use some sort of the word just left me, but they use some form of that. So these are our high-risk patients. Chart 25.2 also has more people, has the people listed that are high-risk patients. Mental status is something we should consider. Impaired mobility, nutritionally challenged. These are our biggest ones. Nutrition is critical. Nutrition is critical for good healing. We've talked about negative nitrogen balance in children who are immobile, and how important it is for them to have a positive nitrogen balance in order for tissues to heal. So they need to have a positive nitrogen balance and adequate protein. So they need to have high calories and high protein. Well, of course, we want to assess labs. We want to weigh them, their ability to eat, make sure whether or not they need supplements. If they are incontinent, we want to make sure that we're using a pH balanced soap, which is somewhat, years ago, Dove was the only pH balanced soap that people recommended for incontinence. Of course, now we have cleansing cloths and things that we can use. Reddened areas should never, ever be massaged directly. It damages those capillary beds and causes increased tissue necrosis. So nutrition is critical. we should make sure we have high protein. In order to maintain a positive nitrogen balance, it requires 30 to 35 calories per kilogram per day to maintain it. So you need to know that 30 to 35 calories per kilogram per day is needed to maintain a positive nitrogen balance. Of course, here are some of the things that we can do and some instruments that we have available to us. We have the pressure relieving devices, which are your ones that actually have capillary pressure measured in a constant state. And then we have the pressure reduction, which just reduces what pressure is applied to the patient, such as a pillow, whereas a pressure relieving device might be your inflated bed. So you have dynamic, which is inflation and deflation of a device, and then you've got static, which is in a constant state of inflation, which is going to offload the patient's pressure. So we should be using them anytime we know that our patient is not able to take care of themselves. Pressure reduction devices only work in conjunction with other measures. And again, positioning is critical. That bed should be at 30 degrees angle. If we have respiratory distressed patients who can't tolerate that 30 degrees, they can still be at 30 degrees but be lying on their side. Or we may have to put them at a 45 degree but really put a lot of pillows around to keep them from sliding down in the bed. We should use a lift sheet instead of pulling the patient up to prevent shear. And then, not shear, but friction, I'm sorry. Shear is where the patient slides down and the tissue separates from the skin, where friction is where something rubs across the skin and causes your damage. So we should always monitor heels. Heels are real bad for breakdown, especially when a patient is in bed. So you want to monitor the heels for breakdown and keep them off the surface of the bed by using your heel protectors. You want to keep bony surfaces separated, like the knees. You'd want to put pillows between the knees. Now my pictures of the stages of the wound do not include the two that the book has this year. They have the one that is suspected, which is just a little reddened area where they suspect that there's a pressure ulcer, and then they go to stage 1. There's also the unstageable, and I don't have a picture of it because this is the first year the book ever came out with those two pictures in it. So what I've got are pictures of stage 1, stage 2, stage 3, which goes all the way through the subcutaneous tissue. Stage 4 goes through the fascia and the muscle down to the bone. Unstageable is when it has eschar or something on top of it, or the size of it is a lot of tunneling and you just cannot stage it. One thing that is for certain is if you have a stage 2 ulcer that progresses to a stage 4 and you get it to heal back up to where it looks more like a stage 2, it will always be a stage 4 ulcer. That's something that you want to think about. But be sure you look at these pictures. I didn't take up your PowerPoint slides just to irritate you with ugly looking pressure ulcers. Be sure you know how to identify each one of those 4 stages that are presented there. Things that you need to assess with your wounds. You want to be sure you know the location, the size, the color. All these things you need to know, whether or not there's any foreign bodies in there. So what about blanching? If a reddened area blanches and returns to red, hey, it's got vessel dilation. It's not got underlying damage. If the color does not blanch or does not return, then you've got tissue damage. So if you've got blanching that does not have the color return, you've got tissue damage, or if it doesn't blanch at all. You should use the face of a clock to describe your location. You really should know how to measure wounds, so you should know that, you know, the length is from like 12 o'clock to 6 o'clock and the width from 9 to 3. You should be measuring how deep the wound is with a cotton swab and measuring that area with a disposable tape measure. And all this should always be recorded, although it's not. Usually when we do see wound care done, we see the dressing change done, we see them look at the whether there's granulation there or not, whether there's any excretion there or not, exudate there, but we don't usually see them measuring the wound. And it's very important to measure a wound, especially if you're really concerned whether it's healing or whether it's not healing. So it's really important. It's important to know that pus alone is not an indicator of infection, because pus is formed from the tissue, the dead tissue being wasted away. So we see pus that comes there. So if you're thinking there may be an infection in a wound, you should watch for an increase in secretions, increase in odor, possible fever of your patient if you're thinking that your wound might be infected. You want to be sure when you have a patient that comes in with a wound to assess their history and identify the cause of the breakdown. Make sure that you know if they're at high risk, and be sure you're inspecting the entire body. So you want to be sure and give them a body, during bed baths, during the morning care is when you can actually inspect under the folds. Folds are, especially with obese people, it's very important to make sure that you look under their folds to make sure that they don't have any drainage there. So we got all different kinds of wound exudate. The serosanguinous is what's normal for the first 48 hours. If you see a sudden increase in that first 48 hours, you're going to be suspicious of dehiscence. And nobody likes dehiscence. You can have purulent, which is usually indicative of possible infection. If it's creamy yellow, it's staph. If it's greenish blue, it's pseudomonas. So all these different things. And so remember that pus alone does not indicate infection. Here's some terms that you need to be familiar with when you're talking about pressure ulcers. Necrotic tissue is just the early stages when it's dry and leathery, a lot of times known as eschar. Eschar lifts and provides a lot of good environment for bacteria to grow, especially as debridement makes it loosen. Hopefully when the dead tissue is lifted, we will see the granulation. Undermining is when the skin separates from the wounds around the edges of your wound. So like if your pressure ulcer, you have stage 2 pressure ulcer, and then up under the skin, instead of it being intact at the edge of the wound, up underneath the skin are tunneling or undermining. And then tunneling occurs in a lot of deep tissue wounds. You may think they're a little small hole, but when you start checking to see how far they tunnel back, some of them can be really big. And these are all the different types of nursing diagnosis that you can have. Impaired skin integrity, of course, if you have any type of skin damage already done. Risk for any infection if you have an open wound. They may have chronic or acute pain, depending on their age, whether they have disturbed body imaging. A lot of them don't know how to cope with it. They don't, usually with your elderly, you don't see good nutrition. Tissue perfusion is not good because they don't know to change their position, and a lot of times they just don't know what they should be doing. So, how are we going to treat these wounds? How are we going to get rid of these pressure ulcers? Well, hopefully we can keep our wound bed moist, not dry, but we don't want it to be too moist. But we want it to be dry. We don't want it to be dry at all. So our dressing types are going to depend on the ulcer and what its characteristics are. Transparent dressings maintain moist moist environment for the wounds, which is a good thing. So usually you will see transparent, you'll see tegaderms over pressure ulcers. If we have a wound that is dry and we want it to stay moist more than just the transparent dressing, we use hydrophobic dressings. They're waterproof and they're non-absorbent, so they don't absorb any of the fluid inside the wound. However, if we have a wound that's got a lot of drainage, we want to use a hydrophilic because it's going to draw the material from the excessive drainage. Again, we're going to use physical therapy, drug therapy, and nutritional therapy. So we're going to be making sure that with our physical therapy, we may be putting them in a whirlpool, making sure we're doing range of motion, making sure we're repositioning them. Drug therapy we may have to put topical antibiotics on them. Nutritional therapy, again, high protein, high calorie. And then we got all these other things that we can do, the electrical stimulation and things. So if we have a wound that's necrotic and with eschar, we're going to have to do surgical debridement, which may be mechanical or chemical. So mechanical means we go in there and actually remove it with scissors or scalpels or whatever we do it, or with chemicals where we would use medication, some type of topical ointment to cause it to actually debride itself. So our drug therapy is going to help remove infected areas directly. We don't want to use systemic antibiotics unless we know there's a systemic sepsis going on. But we will use the topical antibiotics, ointments. Our NPWT, our negative pressure wound therapy, usually works really well, but you never want to use it on a patient with who's on anticoagulant medications. You don't want to use it over organs. You don't want to use it over malignant wounds or gangrenous wounds. So be sure you know what not to use NPWT for. Your electric stimulators contraindicated in people who have pacemakers or wounds over the heart. The hyperbaric oxygen, when we were getting to go through the wound center, y'all saw the hyperbaric chambers. Just administers oxygen under high pressure, increasing the O2 concentration in the plasma. Usually used for specific wounds such as burns, necrotizing fasciitis, brown recluse spider bites, and diabetic ulcers, because diabetic ulcers result from decreased oxygen. And then, of course, we're going to have some grafting that we will put on to try to help protect the wound as it heals. We don't want to put, for the ones that we're putting it on as a dressing, we don't want to use something that would we would want to save for permanent if they need it. But we do need to be sure that we, when we do put the graft on, that we don't disturb the dressing that's on the graft for 3 to 5 days. Most of us, got to get in there and see what the wound looks like. But for 3 to 5 days, we should not touch it at all. Give the epithelial cells time to regenerate and attach to the wound bed. We want to elevate the affected area. We don't want it to become edematous and not allow the skin graft to attach, or whatever type of graft we're using. We don't want to move that limb around a lot, or that wherever that area is. We also want to monitor the graft once we're able to look at the graft after 3 to 5 days for the indication of failure to vascularize, which is usually, you might see a pale flap. And a pale flap's not good. It should have good color to it. If we get our graft from a donor site, we usually dress the donor site with moisture retentive dressings such as a Transderm. Don't want to put pressure there. That donor site is much more painful than the grafted site. It has much more raw nerve endings because they go just by that very top layer of epidermis, and it's not, it's usually like a second-degree burn as far as the way it feels for them. It's very painful, so that we really need to monitor them close. So we've got RN taking care of an obese patient who's been on bed rest for several days. The RN notices that the patient has redness on the sacral area. What would she do? No, we don't want to put them in high Fowlers, because what's that going to happen? It's going to cause pressure on that sacral. Use arms and legs to push when moving self out of bed. That's not going to have any help on preventing a bed sore. If we get a patient up 3 or 4 times a day in a recliner, we're not changing their position off their sacral. So the best answer would be to put them in a side-lying position where they do not have any pressure on the sacral area. Seeing a reddened area on patient's skin, RN presses firmly with fingers at the center of the area and sees the area blanches. This means which factor exists. Well, it's not inflammation. It's not infection. It means that the area blanches when it's reddened, so that we have blood vessel dilation. If it didn't blanch and the area stayed red, then we would have tissue damage. But as long as it blanches and the area returns to red, then our tissue's fine. Okay, our RN's assessing patient's skin, notes a 2 by 2 inch purple color on the coccyx. What stage of pressure ulcer is that? It's a suspected deep tissue injury because we don't know what's under there. So it's just a purplish color. We don't know anything about it. Unstageable, it's not going to be that because we can't even determine if it's actually an ulcer yet or not. We're just suspecting deep tissue injury. So here are some of our common bacteria. Remember how to do your culture. Remember I told you, be sure to know how to do your cultures. We have the bacterial, viral, fungal types of our common infections that we have. The bacterial, we usually see cellulitis, impetigo, folliculitis, and funicles. The folliculitis is usually an inflammation around your hair follicle. The impetigo is caused by Staph aurealis. So those are some things that we have to remember. Impetigo children usually get those. You have to remove the crust by soaking them in warm water and then put antibacterial, use antibacterial soap and put a topical antibiotic on it to try to prevent it from reoccurring. Our bacterial we can treat with antibiotics. Our viral has to be treated with antivirals, such as your Ciclor, Aclivor. Those are things that we're going to put on that we're going to treat the virals with. The ones that we usually are concerned with are the herpes simplex 1 and 2, and of course herpes zoster. The herpes 1 or 2 can be transferred from one body part to another. So you can have type 1 on your genitalia and you can have type 2 on your lip, depending on which type you had and where you transferred it from. It's very easily spread. And herpes zoster, of course, come from patients who've had chickenpox and then have had an outbreak of herpes zoster later on in life. And of course, now we have a Zostafax sub-Q ×1 to prevent shingles. Shingles are contagious to those that have not had chickenpox. They can be spread by respiratory droplets for the first 1 to 3 days, and then the lesions have to crust over before those patients can be taken out of isolation. They should be in isolation. Patients who are pregnant or who have not had the chickenpox should not take care of patients who have shingles. People who have herpes zoster, their initial outbreak is extremely painful. There's no cure for it. We want to make sure that they do protected sex, especially when they have outbreaks. And actually, healthcare providers can develop herpetic whitlows. And herpetic whitlows are usually spread from the nurses taking care of patients' oral secretions and things at over and over again, and they can actually develop herpetic whitlows if the patient has had herpes simplex virus. So I have seen this develop in a lot of healthcare patients, or a lot of healthcare nurses. So the fungus, of course, this is more like a yeast infection. You want to be sure, especially with your obese patients, that you're looking in their folds and put nystatin powder on folds of obese patients to try to prevent yeast from spreading. So a patient has herpes zoster. Which staff members would be best assigned to that patient? Staff members who had chickenpox. Great. Self-care about a minor bacterial skin infection. They should bathe daily with antibacterial soap. A 60-year-old patient wants to have a Zostafax vaccination. What health history should we ask about? We need to know if he's being treated for an autoimmune disease, because Zostafax is a live virus, and if he is immunosuppressed, he could have an extremely bad outbreak of shingles. So we want to make sure we don't give the shingles vaccine to someone who's autoimmune. All right. Cutaneous anthrax, we don't see a whole lot of that usually. But just to address it, because it is in the book, and I'm not sure if I've got any questions on that or not. Actually, yes, I do. I do have a test on that in the book. It's caused by Bacillus anthracis, and usually with us in the United States, it's caused by infected animals and people that catch it, or people that work with those animals, such as the farm workers, the vets. It has been known to be a tool for terrorism, but what you need to watch for is whether or not it is confined to the skin or systemic. Most of the time you'll see a raised vesicle that the center will sink in and necrosis begins. It turns black and it's painless, and that is a big symptom that we look for to diagnose cutaneous anthrax, other than, of course, doing your lab. So you're going to see that black sore on whatever area to the skin that was exposed to the anthrax, and it's usually on the fingers, because you usually handle the animals with your hands. You have to have Cipro or doxycycline for 60 days orally, and you need to take it starting just as soon as you recognize that you may have been exposed to anthrax or you have been contaminated with anthrax. So patient reports painless raised vesicles that itch, bled, and then sank inwards. It's now black. So what would you ask them? The only thing on there is, do you work with or around animals? Just so you'll try to remember it. Pediculosis, scabies, these are all parasitic disorders. Bed bugs are also a parasitic disorder that we have as a nation been trying to address in the last few years. We've been seeing an increase in bed bugs. So the pediculosis and scabies. Pediculosis is a louse and scabies is a mite. And you can have the head louse, like the nice big long one over there, or you can have a pubic or crab louse over there. He looks like a little crab. That's why they call him a crab. They both itch really badly because they bite you. They lay eggs on you. They run around in your hair and cause you to itch and cause you to be miserable. So basically you treat them both the same. You need to wash your clothes in hot water with detergent. You need to wash your linens, your toys, anything that your body or head has touched needs to be washed with usually lindane or permethrin. Lindane can cause lindane poisoning if it's overused. So you want to watch for lethargy in a patient that you may see a lot of lindane being used. It usually works in, the permethrin usually works in one treatment. When you're using, when you have pubic loss, you definitely want to abstain from sex. And you don't want to have sex with the partner that gave it to you because you'll get it back again. And social contacts have to be treated. So just like all infestations of lice and mice, anyone that you have social contact with has to be treated. And sometimes it can be embarrassing to have to tell your friends that, you know, they may have some lice from you or mites from you. Bed bugs usually are hitchhikers from motels or areas that are infested. They're very hard to get rid of. What they do is they don't really live on you, but they have to eat your blood, and it's usually the anticoagulant that they squirt into you to be able to feed for a long period of time. So bed bugs are kind of nasty. So we have bed bug bites, and she's embarrassed. She showers. So it doesn't have anything to do with whether she's clean. It doesn't have anything to do. She won't see bed bugs on her or clothing. They'll be in the mattress or in the, they can be in your headboard. They hide just anywhere and everywhere, and they are just absolutely horrific to try to get rid of. I didn't change my PowerPoint for you. Oh, I'm so embarrassed. Okay, next question. We see linear ridges on the inner aspect of the child's wrist. He reports intense itching, especially at night. What do we expect? With the linear ridges, we're expecting scabies because scabies burrow under the skin and they use linear ridges. And of course, we're still going to treat them just like we would the head lice. And I'm going to stop right here so that I can not have too long of a PowerPoint that won't record.